Welcome back. Now we have with us Dr. Naghman Zuberi. He has been teaching in Margla Dental Health Sciences College too. Now he's in Canada currently, and he's a teacher working for students to pass their Canadian dentist license. We have Sir with us, and he will be delivering a lecture on proximal caries and fluorides. Assalamu alaikum, Sir. Welcome. Kindly introduce yourself.
Walaikum assalam. Thank you. And everybody, it's 14th of August. So, very happy Independence Day to all of you. And today, we will be discussing about the proximal caries and fluorides. My name is Naghman Zuberi. Most of you know me firstly from the dental schools. I was in Pakistan, and then I had a private practice over there as well. And currently, I'm in Canada, and I train for Canadian dental exams. Like I teach them for passing their theory exams, as well as I teach for American board exams, and I'm doing it for last almost you can say 12 years, and Alhamdulillah, very carrying very good reputation in this field. So Dr. Farooq, he contacted me and he said that would you please able to deliver few lectures for my channel. I said, why not? Knowledge always it increases when you share your knowledge. So I'm here with this today's topic, that is proximal caries and fluorides. So let's start with the today's topic. Dental caries is basically a progressive and it is irreversible. It is not reversible disease. It's a microbial disease as far as we all came to a consent that it is. This is a consensus among the researchers now that bacteria, they are involved in dental caries. It affects the hard parts of the tooth, which are exposed to the oral environment. Keep this thing in mind. Those parts are affected which are exposed to the oral environment, resulting in demineralization of the inorganic constituents and dissolution of the organic constituents, thereby leading to a cavity formation. When we talk about this word caries, what is the origin? It could be coming from the Latin, which means rot or decay, or it may be coming from the Greek word care, which means death. So whatever the situation is, basically it is rotting or decaying our teeth or even making our teeth non-vital. Food is the major source of causing dental caries, and we cannot live without food. So we cannot avoid caries to happen, but we can prevent the caries from happening. How? We will discuss it. So there is a relationship between diet and dental caries. When bacteria are present in our oral cavity all the time. So when the fermentable carbohydrates from our food and bacteria, they come in contact, they produce acid. And that acid, it acts on hard surfaces of teeth and produce the caries, demineralization of the hard structures. Well, if we look at the current trends in caries and the incidence, in developed countries, caries prevalence has declined in the last a decade or two. Reasons are multifactorial, like communal water fluoridation, awareness, oral hygiene maintenance. Too much awareness and then a lot of stress on oral hygiene maintenance by the dentists, by the doctors, even by the school programs. In developing countries, there is an increase in caries prevalence, and biggest cause is increase because of consumption of the refined sugar or refined carbohydrates. Whatever the situation was like in 1950s in the developed countries, that condition is now in the developing countries. Too much sugar intake. So frequency of fermentable carbohydrates matter, not the quantity. Like if you say that someone is consuming 500 grams of sugar in one go, would not be prone to have caries as much as a person who is having uh, like you can say 100 grams of sugar but in divide 20 grams after every couple of hours. That person would be more prone to have caries. So frequency matters, not the quantity. Prevalence of caries on individual tooth surfaces and its distribution. There is a bilateral distribution between the right and left quadrant of both maxillary and mandibular arches. Means no matter it is right or it is left, equally both can be affected. Mandibular central incisors are least likely to experience caries, while maxillary and mandibular molars, they demonstrate the highest caries rates. Maxillary teeth are more susceptible to caries than the mandibular teeth. Aproximal surfaces of incisors, canines, and premolars have higher caries rates than other sides. On the other hand, occlusal surfaces of molars, they show the highest caries rates. Gender and age has no effect. However, women generally have more caries than men. Reason would be they have a sweeter tooth. Caries teeth are more common among younger patients, and this rate decreases as the age advances. When we look at the susceptibility of individual teeth, upper and lower first molar, 95%. Upper and lower second molars, 75%. Upper second bicuspid, 45%. Upper first bicuspid, 35%. Lower second bicuspid, 35%. Upper central incisors and lateral incisors, almost 30%. Upper cuspids and lower first bicuspid, 10%. Lower central and lateral incisors, 3% only. Lower cuspids, 3% only. Teeth which are farthest back in the mouth, they are more frequently caries. Means the distal most teeth, they are more frequently caries. And when we look at the individual tooth surfaces, occlusal, like we are talking about molar, occlusal, then comes the proximal, then comes the buccal, and then comes the lingual surface. The economic implication of dental caries. Factors changing the economic implication of dental treatment, there's dental caries are economic status of population. Nowadays, caries is more prevalent among the low socioeconomic group. Then it is increasing educational status. Definitely, when the educational status is increasing, people have becoming more aware of the situation. So another influence of the increasing educational status is aesthetics. The aesthetics is also taking a lot of, you can say, importance in the life of people. So they are more cautious about keeping the oral hygiene, and they are maintaining their oral hygiene meticulously. Growing number of dental graduates. So now dentists are available, like if you talk about North America, like in every single strip mall or plaza, you can see one or two dental clinics over there. So very easily people can access dental surgeons now or dentists now. Insurance. Previously, the problem was that finance is a major issue, but now insurance programs, they are there, and people can rely on the insurance and they can seek the dental treatment. Then the commercial pressure. As I have already mentioned, definitely if teeth is a part of the personality and bad teeth, definitely person is not going to be that much commercially acceptable. Then governmental influences. Governments, they have worked very hard over the last couple of years in most of the advanced countries, and they have influenced that we should at least bring the caries, prevalence of the caries or incidence of the caries to as minimal as possible. Well, all of us, we are aware that Black, he has classified the caries or cavities as class 1, class 2, class 3, class 4, class 5, and class 6. We are not going into the detail of these, just we know that the class 2 is proximal caries in posterior teeth, and class 3, these are the cavities on the proximal surfaces of anterior teeth, no matter upper or lower. Well, we also classify dental caries according to the location on individual teeth, like pit and fissure caries, smooth surface caries, and root caries, or according to the rapidity of the process, like acute dental caries, chronic dental caries, as well as primary caries and secondary caries. Incipient caries. Incipient caries are those where you cannot see clinically, but when you take the radiograph, you can see some demineralization on the radiograph. That is called an incipient caries. All of us, we are having a consensus that S mutans, that these are present in like some amount which will cause the caries. Then comes the frequent sugar supply. It gives mutants a competitive advantage. Excretion of cytosolic proteins helps adhere them firmly to the tooth surface. Metabolism of sugar to acid byproducts lowers the pH. Few organisms can survive in low pH, and S mutants, they can survive. That's why they are called aciduric. Mutants proportion increase now because the situation is in their favor. This lowers the pH further and decreases the number of competing organisms. Once the pH low enough, like it is in critical level now, between 5 and 5.5, tooth mineral begins dissolving. So mineral loss follows down the grain of the enamel rods, and further there would be chances of cavitation as well. But in the beginning, there is no cavitation. The outer surface is intact. It is intact. When we look at the etiological factors in dental caries is a multifactorial disease in which there is an interplay of three principal factors. And what are those? These are the host factor, then comes the diet, and then comes the microorganisms. But time is also very important. That is why right after having the food, if someone cleans their teeth, brush their teeth, then the time won't be that much critical that it may initiate the caries. So fourth factor, apart from these three factors, is also very important. The host factor we are talking about, these are teeth, then the quality of saliva, all we are not going at the moment in the detail. Microflora, all of us, we have just talked about that. S mutans, these are the bacteria which are basically known for causing the caries, and substrate, that is diet. When we look at the proximal caries, what happens actually? The bacteria, they start colonizing when they get some stagnant areas, and at that time the proliferation of bacteria, it is increases as the environment it becomes more suitable. Once the critical number as well as the critical pH it has been achieved, then the demineralization it starts. Before cavitation, if a process of remineralization starts, you can reduce the size of caries or even you can eradicate it. So keep in mind, if there is no cavitation, there is no restoration. We only work with oral hygiene maintenance if we have caries which are confined only to the enamel and the outer surface of the tooth is intact. Only we can see those caries on the X-rays. Smooth surface caries. The earliest manifestation is the appearance of an area of decalcification beneath dental plaque with a smooth chalky white area. Loss of interprismatic substance with increase in prominence and roughening of ends of enamel rods. Accentuation of incremental stria of radius. So they start becoming quite accentuated. At this process advances and when it advances and involves the deeper layer of enamel, it forms a cone-shaped lesion with apex towards the dentino-enamel junction, and the base will be towards the outer surface of the tooth or surface of the tooth. I will show you that. This is how it will look like. It will be a triangle. As I told you, that outer surface will be intact at this time. Only the inner surface will be demineralized and it will be having a triangular shape. Even on the radiograph, you will see it as a triangle with the base towards the outer surface and the apex towards the dentino-enamel junction. How to interpret the dental caries on radiograph? Well, proximal caries, as I told you, it will start on the inner side of the enamel and it will progress in the form of a triangle whose apex will be towards the dentino-enamel junction. Whereas occlusal caries, the pits and fissure caries, they will start in the pits and fissure and they will also progress in the form of a triangle. But the apex of the triangle will be towards the occlusal surface or outer surface, and base of the triangle will be towards the dentino-enamel junction. But once caries, they cross, no matter it is occlusal or it is proximal caries, once they cross the dentino-enamel junction, they will acquire the shape of another triangle whose base will be towards the dentino-enamel junction and apex will be towards the pulp, no matter they are occlusal or they are proximal caries. Well, where to locate these proximal caries? If we look at a radiograph, I have just enlarged this picture to make you aware of the fact that where we are looking. This is the contact area of two teeth. This is the crest of the ridge, interdental crest, and this is the cemento-enamel junction of one tooth. This is the cemento-enamel junction of the other tooth. The start or initiation of the proximal caries will be detected just close to the contact area or below the contact area up to the crest of the ridge. This rectangle, you will be finding the initiation of the proximal caries in this area. Prevention is better than cure, and even nature is very kind to us. It gives us very good time. Caries in enamel, they progress at a very slow rate, like up to 8 years it takes before the cavitation is going to occur. 7 to 8 years. If you go into the book by Sturdivant, you will see over there it is very clearly mentioned. And even if someone has like incipient caries or caries they have affected like 1/4 or 1/3 or even half of the enamel, or even not yet reached the dentino-enamel junction and cavitation is not there, you can reverse the process by maintaining the oral hygiene, by application of fluorides. Methods to control caries. There are different methods like chemical measures, nutritional measures, and the mechanical measures. Well, when we talk about the chemical measures, fluoride is the major chemical which we use nowadays for controlling the caries. In nutritional measures, we will definitely cut down the refined sugars, and we will ask the patient to have more of those nutrients which will be having some phosphates in it, some calcium in it, etc., etc. And mechanical measures, brushing. Tooth brushing is the most important tool. No matter it is a toothbrush or you use a chewing stick or the miswak, or whatever, depending upon culture to culture, but mechanical means are very important. And then floss as well. Fluorides, most widely used and promising chemical in this category of chemical measures. Fluorides have been administered principally in two ways: systemic application, like in community water or school water fluoridation, milk fluoridation, or even self fluoridation that people they bring drops or tablets and then they consume it. Topical applications: sodium fluoride, acidulated phosphate fluoride, stannous fluoride, self application, or professional application. A fluoride concentration of 1 part per million in drinking water is associated with a marked decrease in dental caries. That was the concept which we were carrying since the early 1900s. But now we say that even the fluoride concentration of 0.7 parts per million is also adequate. And this concentration also depends upon the temperature of that area, like the environmental temperature. When the temperature is higher, lesser amount is also helpful. When the temperature is colder, then definitely you need some higher concentration of fluoride in the water. Other methods of using fluorides are dietary supplementation of fluoride, which I have already mentioned, fluoride dentifrices, then fluoride in mouthwashes or rinses, fluoride incorporated in chewing gums or even in dental floss. Rinses for caries reduction. Aqueous sodium fluoride. Concentration is 0.2%. The pH will be 7. Application once a week or once every 2 weeks. Aqueous sodium fluoride, 0.05% concentration. Its pH is 7. You can use it on daily basis once only. Aqueous APF, acidulated phosphorylated that fluoride gel. It is aqueous, 0.02%. Its pH is high, it's low. It is acidulated, and you can use it once daily. The effect of fluoride influencing its anti-caries action. There is interference in enzymatic process of bacteria, then direct bactericidal action, reduction of plaque formation, enhancement of enamel remineralization, stimulation of formation of large apatite crystals, and lowers the solubility of enamel. What are the goals of fluoride administration? First of all, do not harm the patient as we do in each and every single treatment. What does it mean? I will let you know. Prevent decay on intact dental surfaces, arrest active decay, and remineralize decalcified tooth surfaces. So over here, beneficence and non-maleficence both work together. How? Do not give fluoride in such a high concentration that it may lead to fluorosis, or even if people they ingest very high level of, like very high concentration of fluoride, it may cause toxicity as well. So we have to be careful in administering the amount of fluoride. It will prevent the decay on intact dental surfaces, as well as if some active decay is going on underneath the outer surface of enamel, that is going to be arrested as well. And where the decay is already done, and if the outer surface is intact, then remineralization of decalcified teeth, it will also start. Well, as I told you previously, we were talking about 1 part per million as the optimal dose. But now we are of the opinion that anywhere between 0.5% to like 1 part per million, 0.5 to 1 part per million, that is okay. The fluorosis, it starts showing at 1 part per million. And as the amount is going to be increased, then the fluorosis is going to be increased as well. Whereas if you see the DMFT rate, it is going to decrease till 1, but then the decrease is very slight. That is why do not consider that if I will give 2 part per million, 3 part per million, or 4 part per million, the caries rate is going to be lessened. No, that is not going to happen. 1 part per million is good. Or if you are talking about the amount of fluoride in dietary intake, it should be 0.1 milligram per kilogram body weight. Otherwise, if it will be more than that, it will cause fluorosis. So over here, we are done with our today's lecture, and soon I will meet you again with our other lectures as we are continuing the lecture series on occlusion. So see you on Monday at 9:30 a.m. Toronto time or Eastern.
Thanks a lot, sir. It was a very great lecture. Jashn Zadi Mubarak again, sir. Khuda Hafiz.
Thank you very much. Allah Hafiz.